Okay, hi guys. Let's just go through a few cases then, and I'm filling in for Emma, who hopefully will join us halfway through and go through a few other cases that we've done. So I've just pulled some from my favourite journal, which I don't know if you read cases from the ASE guys, but they just have some great stuff. And this is from last month's efforts. I'll do this as we would for like a DDU exam. So classically, you got about 7 or 8 minutes per case. Give you a stem to kick off with, so something like this. So 47-year-old man, 1 week history of progressive cough. That's on a background of a 6-month history of gradually progressive shortness of breath. No other post-medical history. Significantly hypoxic and febrile when they come into the emergency department. They get put onto non-invasive, and I don't know, I've probably got a few feelings about putting someone with a CT that looks like that on non-invasive, but we'll leave that aside. But they end up getting intubated. Day 7, they have a sudden increase in heart rate. So these are kind of focused echoes with someone with a sort of on the POCUS side of things, but I know there's some dodgy images in there. And these are also from the Mayo Clinic, I should add. So they actually do things 180 degrees around the wrong way. So let me just quickly loop that for you. I apologize. The rest of them should be okay, excuse me. Juan, do you want to kick this off?
So this appears to be a subcostal image. I think of a 4-chamber view subcostal. The most significant abnormality that I can identify, there's a independently mobile mass traversing between the right atrium and the right ventricle across the tricuspid valve. It's very large in nature. So obviously has very high risk of embolization. Other abnormalities that I can see, the RV, I mean, the RV gives the impression of being dilated, and there's bowing of the interventricular septum towards the LV, which might suggest the volume, at least the degree of volume, if not pressure, probably pressure overload as well. The LV itself looks small, looks like normal walls, but small cavity size. It might be due to foreshortening, but it looks like in some beats the LV walls are kissing. So this could either represent overall hypovolemia or failure of blood delivery from the right side due to RV dysfunction. The aortic valve appears to be open.
Pull that back a bit. So I've given you the clinical history. Just let me pull you back just for 1 second. What do you think what's the differential diagnosis for why we're doing this echo? You've got a sudden increase in heart rate, having been intubated for a week. So what's the differential?
I mean, with the history and what I've seen, I would suspect that this patient has had potentially a vegetation, so infective endocarditis, or it could be a non-infective endocarditis that has been embolized into the lung and causing infective and inflammatory process in the lung. Yeah. A sudden increase in heart rate.
Would that give you, I guess, for the infective, we're talking about a sudden increase in heart rate. So I'll just say that when we're giving you the stems, everything is relevant. It probably wouldn't be as big as this, to be honest, in the DDU exam. We'd probably keep it a little bit simpler. But the idea of this sudden increase in heart rate for me is really important. So again, maybe it's just the way I'm wording it. Forgive me as I'm
sorry, I was just I think I'm not getting to the point. I was going to say with the sudden increase in heart rate, I would worry about PE. PE would be my primary diagnosis.
When we got 7 minutes, you classically got a minute per slide in the exam. And I guess the trick I'll be giving you is get to the money pretty fast, because I think talking about hypovolemia and talking about volume overloads, I think, I'm sure they'll be in there, but the fact that we've got this massive thing that's flicking in and out, and I guess the next part I'm going to show you would be this, which is showing you the difference in the echo from day 1 to when we've had this sudden increase. And again, this is a Mayo image, so the image is flipped, so it's the right ventricle is on the right side of the image. So do your best and let them their subcostals around the wrong way, and it's so that they can match up with their MRIs. But you can see, I think, that there's this marked difference between one to the next. So if I could suggest one thing, you know, with the exam, it's going to be about trying to make sure that you get that examiner on side real fast, so that you're getting to the money quickly. And I think you sort of started off by doing that, talking about this large, you know, it looks like it's a large, you know, irregular, you know, independently mobile mass flicking in and out the RA to the RV, massive RV overload, massive RV there, which is clearly dysfunctional. You can see that that part's not working well, and squashing the LV. So we got, you know, if that's got signs with a significant heart rate, you know, I think we've got signs as well as echo features of cor pulmonale. And so just getting to that pretty fast, you know, I think talking about hypovolemia when you've got this mass in there, I think goes lower down the differential, right?
Yeah.
Nice. All right. Run me through, have you done a bit of transesophageal? I presume so, seeing as
I have.
Yeah, sweet. All right, so first of all, just give me your findings on this and I'll just fire a couple more questions at you. So this is, sorry, the patient has to tell you what went on. So the guy had that massive PE that you saw, that was a thrombus in transit. The patient, after the sudden, whilst they were having this echo, they suddenly lost the mass that was sitting there in the right ventricle and right atrium, and the patient had profound hemodynamic deterioration. And so they were urgently put onto ECMO. All right. Luckily, this patient survived. And then this is the transesophageal images after the ECMO had been done. So can you just talk me through what you see?
This is a mid-esophageal 4-chamber view. What I can see is that I'm just gonna, is it okay if I'm systematic? Is that
yeah, interesting. I mean, absolutely, I think it is. But in the exam, I think it's getting to the, you know, I guess being systematic, the answer to that question is yes, you've got to be systematic, make sure you don't miss stuff. But I guess it's a bit like doing the hot cases in the exams. You know, I still think if you've been asked to examine someone and tell me, are they ready to come off ventilation, you know, you've got to talk about the relevant stuff in there. I don't, you know, talking all about your findings from top to bottom as you would in the med school thing doesn't quite work. You know, it's getting to the money fast. You know, you're expected to be at a pretty high level. So
okay,
have a crack, and we'll just, you know, that's what it's all about.
I'll have a crack. So the most significant abnormality here is that the RV, there's still a degree of RV dysfunction. The RV size appears to be at least mildly, if not mild to moderately dilated. The longitudinal contraction appears preserved, but the RV free wall maybe has reduced contractility. I think what's concerning to me is that there appears to be echogenic material near the RV apex. Maybe in the context of this patient, I'd be concerned that there's still residual thrombus.
Very nice. Okay, that's really, and I think that's it. Now you went right. I think that's the money. That's the relevant part of this is picking up. It's relatively subtle. You know, I think candidates that don't know about TOE would probably call that a normal RV potentially. I think you've picked it up. I think we've still got some sign of RV dysfunction. Let me just ask a few anatomical things then. So, which leaflets are we looking at in the mitral valve?
Which scallops?
Yeah, I was going to start with leaflets, but yeah, straight to the scallops. I presume you can tell me which is anterior and posterior then.
I still haven't mastered this, to be honest, but obviously the anterior leaflet's the one to the left.
Yeah, great.
And that's the longer leaflet on this view, and then the posterior, actually, and the posterior leaflet's obviously the other side. And I think here we're looking at A2 and P2.
Yeah, when in doubt, always say A2, I reckon. Nice. And then the other one?
The other one, P2 as well.
Yeah, I'll go with that as well. Very nice. Yeah. Okay, walls of the chamber. What's this wall here and what's this wall there?
Oh, can you point again? Which one?
Oh, just both of the left ventricle. So which it's obviously septum. Is it anterior or posterior? Anterior infraseptum.
It's infraseptal and anterolateral.
Fantastic, beautiful. And how about the leaflets of the tricuspid valve? Which ones are we looking at here?
you'd be looking at the anterior on the right, and then I assume it'd be the septal rather than
very
posterior.
nice.
Yeah.
I think, yeah, very nice. So yeah, I think you'd have the anterior on the right and the septal on the left. Very good. Cheers, man. Jamal, do you want to crack at another one? Jamal,
sure. I'm on my phone, and but I'll give it a shot.
This is not subtle.
Okay. Mm-hmm.
You should be able to, you'll get this on the phone. Okay, 83-year-old presents with acute bilateral lower limb paralysis. He's got a background of being a vasculopath, hypertensive, hypercholesterolemia. He comes in a little bit hypoxic with profound lower limb mottling and no pulses. Urgent CT with contrast done, and you can see here we've got a massive occlusive mass sitting there in the aorta, and we've also got the renal infarct. What do you think?
I'm just getting my phone in correct orientation. So in the absence of omniplane imaging or a symbol, this would suggest that this is a subcostal view.
Yep.
So if this is a subcostal view, which is somewhat off axis, the chambers closest to the top of the screen would be the right side of the heart, which might also be consistent with which is probably some kind of metal wiring going through the right side of the heart. That leaves the left side of the heart being more inferior. The most striking feature of this subcostal left-sided view is what appears to be simply enormous mass taking up almost the entirety of the left atrium and prolapsing down through the mitral valve.
Beautiful. And if you're going to tell me about a mass, you're going to describe it a little bit further for me, please?
So again, what's coming through with me is quite choppy.
Excuse me.
It looks heterogeneous, but that might be due to some of the artifact that's coming down from the other features in the near field. But it does look heterogeneous in nature. It is smooth-walled, and it is most definitely prolapsing through the mitral valve. The differentials are wide in this kind of situation, but given the patient's history, you would be concerned about some degree of arterial thrombus.
Yeah, great job. I think it kind of does the same thing, but give me the differential for this mass. Let me stick with this one. Keep going with the differential. So you said it was smooth walled, heterogeneous, enormous.
Yeah. Well, given this patient's history, it's most likely to be arterial thrombus. The differentials for echo findings are broad and include vegetations, tumors, secondary, primary tumor masses, and they would probably be the leading concerns.
Beautiful. So tell me, are primary or secondary tumors more common in patients?
Secondary tumors and metastases are wildly more common than primary malignancies of the heart.
And what metastasizes to the heart?
A number of, I think the usual lung, breast, melanoma. I don't have a list to hand.
Oh, that's good. I sort of have the double thing. So the big ones for me are also kidneys, and they're particularly giving a mass that comes up into the right atrium. So yeah, lungs, breast, kidneys, and I really like a differential. You know, you're always going to talk about thrombus first, particularly after I showed you that he's got that enormous amount of thrombus and a renal infarct. So clinical context tells you what to say first, and it's either thrombus or infection, and if it's not thrombus or infection, it's probably still thrombus or infection. And after that, you've got the usual things like, I think you mentioned most of them, the iatrogenic structures like pacing wires or lines, normal anatomical variants, which clearly this is not. Artifacts, don't forget those in the exam. So just when we're talking a little bit about exam technique, I think obviously everyone knows about them, but somehow when we're writing like written questions, we forget to mention those three, and you can lose an enormous amount of marks in the written by forgetting to talk about things we stick in patients, iatrogenic structures, artifacts, and normal anatomical variants. And the last bit is just to know about the tumors. So one of the things that grabs me about this I love this case for a couple of reasons. So first of all is I think the clinical context is clearly one of thrombus, like Jamal said, but it looks for all love nor money, and it actually was on autopsy for this guy who unfortunately died for a myxoma. And you started off sort of going down that track talking about this sort of smooth, massive structure sitting in the left atrium. But I think it's associated with a whole bunch of thrombus, obviously, that seems to have formed in this guy for whatever reason, because I think that's what this tail is. You know, it's got to be thrombus with the left atrial mass. I don't, you know, whether the left atrial mass is what's causing the thrombus from a, you know, static blood flow, but or there's another pathology and it's just a linking onto it. You know, I think that's quite a nice case for that. Emma, do you want me to carry on? I've got a couple more cases, or do you want to go on to yours?
Oh, you can carry on. You can carry on.
No, you can do yours if you want. Do you want to see yours? I'm happy to go. I've done half of that. Do you want?
Yeah, well, but do you want to use this computer? Is it?
Yeah. Is it a DICOM?
No, these are on a cloud.
Oh, go for it. All right, that's enough of me rabbiting on. You can listen to Emma rabbit on.
Well, I'm hopefully going to get them to tell me all the answers.
Nice.
I was going to do them.
Oh, sorry. It's all right. Just stop the share just for a second. Was it into hospital? All right, fellas, just coming up now. Sorry for the delay.
You guys, so I might just show you some loops and you can see what you see. Again, with sort of a bit of an exam focus. So trying to keep it succinct if it loads. I just had the most wonderful tour that I could have shown.
Oh, really? Sorry, guys, it's PowerPoint and Apple having a war.
No problem.
I think this case is worth the wait. It's pretty cool.
What was the toe, or are you going to present it another time?
Maybe I'll talk about it another time. Yeah.
Oh, you can't leave us
Lots,
like that.
yeah. Just lots of very basic pathology, but lovely. You know, just valvular disease and beautiful views of the RV inflow view at the transgastric region with just severe TR and some of the findings.
Should we just, while this is, I don't know why this is taking so long, should we just present another case quickly, just not to waste everyone's time? Why don't we just, while that one's loading, let's just do this one quickly. Okay, 58-year-old man, falls at home, left hemiparesis. Oh, this is a great one, actually. I like this one. Well, this one's for you. Okay, so yeah, 58, falls at home, left hemiparesis, background of hypertension, normal CT brain, he gets thrombolized for obviously a stroke and gets sent off for a thrombectomy. They find M2 and M3 branches occluded on the right, and then he's intubated for this procedure, unfortunately, so hence comes to your unit after that. But you get him back and he's having rapidly escalating levels of catecholamines. So take me through what's going on.
I mean, the most obvious abnormality is echo-free area where I think in the pericardium. So I think that the patient's got a pericardial effusion. On this wall chamber view, there seems to be some inversion of the right atrium, and I'd have to slow it down to see at what stage of the cardiac cycle it is.
Well, which time of the cardiac cycle would you expect it to be in for the right atrium and the right ventricle?
It's at end systole.
Beautiful. And for the right ventricle?
And diastole.
Yeah, do you know early or late?
It's late.
Yeah.
Or
think we both.
No,
I saw that early in my mind, because that's when the pressure is often the lowest. But I agree.
Yeah.
And
but there's quite significant compression of the RV here, which makes me suspect that the patient's experiencing cardiac tamponade.
Yeah,
certainly would fit with a clinical presentation.
Yeah, so we've got acute, rapidly escalating catecholamine. So clearly the patient is in shock. And I completely agree with that. Echo free space and things collapsing. We've got tamponade. Okay, this is the next slightly dodgy image.
I think this is the apical 3-chamber view, which shows color flow image of aortic regurgitation.
What do you think's going on?
So I think, putting it all together, I would be concerned that the patient suffered a aortic dissection.
Yeah, very nice, excellent. And I guess for me, this is why it's really nicely described in the exam for me. Sorry, in the PDF of this case, because for me, I think this is sort of what it's all about for us learning about critical care echo. It's being able to, you know, with the clinical story and this, you've got to be worried about dissection. It's all about putting echo features and clinical features together, which is what we're going. So I'm going to show you a couple more pictures. You've got to tell me what the pictures are and what's the and describe the abnormality. Oh, sorry, you're on mute, buddy.
Sorry, this is an ultrasound of the patient's neck. You can see the internal jugular anteriorly, and below that is the carotid artery, internal carotid artery. There seems to be what looks like I guess there's a echo. I don't know how to describe this, but basically there's 2 lumens.
Yeah, nice.
Which makes me suspect that this is dissection.
Yeah, nice. So what are the 2 lumens called, and which one's which?
Oh, the true and the false lumen.
Yeah, so which one's the true, which one's the false? And how do you tell the difference?
I would have to put color flow through them, and trace the dissection flap to its origin. Yeah,
beauty. But if I don't give that to you, if you had to make a call on this, if I was making you bet your mortgage on it, if I was forcing you into a corner, like I would in the exam, because there are 2D features you can, I think there are ways that you might be able to tell which is which on this.
I would assume the true lumen is it's on the left.
Yeah, nice. I agree.
Pulsating into the false lumen.
Excellent, beautiful. So this one seems to have worse morphology. Is it perfect? No, but it's just one of those features. Beautiful. And you wanted to then try and trace the dissection flat back, which is what they're trying to do here. But you can see it with the pulsation, it goes towards the false lumen. And then you wanted the color Doppler, which again, I think shows here that the smaller lumen is the one with the pulsatile nature in it. And that's how you pick up the lumen. Nice one. Right, let's see if Emma's cases are ready. Yes.
Yay. No. Just...
All right, so I'm going to go there. I'm going to go share screen. Share.
Jamal, do you want to have a go at just describing?
Am I allowed to say, I do apologize. I have another meeting I've got to go to. I'm sorry, fellas. Thank you very much for joining. Thank you for taking over.
Thanks.
I'll see you guys a little bit later.
Thanks very much, Sam.
Thank you so much, Sam.
Cheers.
Jamal, do you want to
stop recording?
This lady, I will. This lady is in her 50s and she presents to ED with worsening leg edema, and she's hypoxic but hasn't got too much respiratory distress. She's a little bit peripherally cyanosed, and has some signs of maybe some clubbing, and presents with mainly a little bit short of breath and leg swelling.
I'm not seeing anything. It's still spinning and saying that you've started screen sharing.
Oh, it's not playing.
Juan, can you see it?
I can see it, yes.
You can see it. I'll try and change my screen view. Meeting settings.
Thanks. Just whilst we're doing that, oh yeah, I'll give you a bit of time.
I don't know what, I'm just, there we are. Okay, I just changed my view settings.
You good?
Okay, so I guess the clinical history here is a 50-year-old woman with increasing dyspnea, hypoxia, and signs of failure and clubbing. The clubbing suggests a more long-term issue, I imagine. This is a peristernal long axis of transthoracic, and I think the immediately most striking feature is a disproportionately large right ventricle. So some would say that you should have a rule of thirds with the aorta, left atrium, and right ventricle, but the right ventricle that we're seeing here probably takes up half of the screen. Again, I'm not getting amazing resolution through my phone, but even this does seem to suggest that there is abnormal motion of the intraventricular septum with bowing into the left ventricular cavity.
Now, just for time, I might just skip you through and we'll keep talking.
So this is peristernal short axis, looking again primarily somewhere probably the mid region of the left ventricle. Again, the most striking feature is the enormous right ventricle with D-shaped abnormality of the left ventricle, suggesting chronic right ventricular pressure or volume overload. You would need an ECG gating to determine which is more likely of the two. Oh, there it is, down there.
Okay, yeah, it doesn't tell you whether it's acute or chronic though. Hey, that flattening, you can get flattening in whether it's acute or chronic. It just tells you the timing. Yeah,
there is some suggestion of, given the chronicity of the patient's symptoms, the clubbing, and there is some suggestions that right ventricular wall in the apex of this screen is a bit hypertrophied, then it is more likely that it is a long-term chronic process. But yeah, the features of right ventricular dilatation could be either.
Yeah, absolutely. And so, I mean, it's the clinical history that gives you that and some of the 2D features, but I don't think you'd be able to tell on this particular loop, but you're absolutely right. So flattening in systole is, you said?
Pressure,
nice. And then flattening diastole, volume. So she was obviously flattened throughout. What do you think of the 4-chamber?
I'm just optimizing.
Yeah.
Sorry?
Describe what's been done here as well.
I'm just letting that play on my phone. So this is there we go. So I'm just having a look. So this is an apical 4. Apical 4 chamber, again, it reinforces these features we've seen about the right ventricle. There is a lot of bubbles coming through. So I'd imagine they're performing some kind of bubble study. Again, from the timing, I can't tell when it moves into the left ventricle, but there is definitely a large amount of bubbles going into the left ventricle. So this would suggest an abnormal communication between the chambers. There's another feature in the far field, which is quite large and abnormal into the right atrium. So whether or not this suggests a dilated coronary sinus, which is in keeping with the abnormalities of bubbles as well. But I think that's probably a dilated coronary sinus.
Yes, possibly it would fit, wouldn't it, with the pulmonary hypertension that we're seeing, which we think has chronicity to it. So what do you think? So how do you differentiate between, with a bubble study, an intracardiac shunt from a different type of shunt, like an intrapulmonary shunt from hepatorenal or something like that?
Sometimes it depends about where you inject the bubbles and the number of cycles before which it appears in the left side of the heart. Within a larger number of cycles is a kind of normal transit, but within about 3 beats of injection is sometimes considered to be abnormal. Again, I can't tell the timing of the bubbles from this loop, but also if you inject if you inject the contrast into one of the left veins, so the veins on the left side of the patient, that can be used to delineate if there's a left upper SVC.
Yeah, if you want to look for a left SVC. But if you're just doing a bubble study to look for an intraatrial shunt, what kind of cutoff do you have? And it's in the guidelines of how many cycles would you if it was an intracardiac shunt across the.
I think I have 3 cycles.
Yeah, 3 to 5. I think it depends on which one you read, but I think they say sort of within 3 to 5 cycles. And there's an and to that. You need to ideally see it actually crossing the intraatrial septum as well. So those 2 things together, and there are obviously caveats that cause false negatives and false positives, which you'll need to be aware of for the exams. You know, things like not doing an adequate Valsalva and things like that for the right to left shunt in PFO, or brisk IVC flow coming in, causing negative contrast. So you think that could be a left to right shunt, but in fact it's just your IVC flow coming in. So there's a couple of false negatives and positive things to be aware of. The other thing is, if it comes through, say, after 5 cycles, and you see it coming in through the pulmonary veins, what might that tell you? What kind of shunt might that be?
Well, I guess, is that more likely to be intrapulmonary?
Yeah, exactly, like a patapulmonary. So would it be normal to see any bubbles in the left side?
Not normal, no.
Yeah, good. Okay, so the normal thing is obviously no bubbles. The suggestion of an intracardiac or intraatrial shunt is seeing it within 5 cycles and seeing it cross the intraatrial septum, ideally. Hard with TT, obviously easier with TOE. And then the non-cardiac shunt or intrapulmonary shunt, such as a hepatorenal syndrome, will generally be after 5 cycles, and ideally you would see it coming in, the bubbles coming in through the pulmonary veins, and that's sort of how you tell. So what are you suspecting here, Jamal? And so what are you seeing? Like, can you just describe what we're seeing with the bubbles in terms of the direction of the shunt and why you might think that is?
I'm just trying to, again, just watching it on my phone.
We can, well, yeah, maybe I'll just skip through actually and show you. So she's got signs of pulmonary hypertension and pulmonary vascular resistance there. Her RV longitudinal function is okay, but the radial function is down, so fractional area change is down. She's got an interesting hepatic vein profile, which I think is nice to point out. So pulmonary hypertension, classically, you get this loss of diastolic flow, and then you get this really prominent airwave reversal. So that's classic of chronic pulmonary hypertension. And there's some nice papers that you can read for that. This one's particularly nice by Fadl, spectral Doppler of hepatic veins and pulmonary hypertension, something for you to read a bit later. I just want to bring you to the subcostal view. So what do you think then about the intraatrial septum here?
Just watching it go. So this is the subcostal, as you say. I guess the interest here is the color on the intraatrial septum, and there does appear to be, I'm just watching it, there's a flash there of flow across, so that is blue away from the transducer, so there's definitely flow across that intraatrial abnormality.
Yes. So
whether or not it's bidirectional, it's hard for me to tell on this, but you could just put spectral through it, and that would tell you when it is in the cycle and whether it's bidirectional, or help quantify that more so than the color. Yeah.
So what are you thinking this could be, Jamal? What's your sort of list of differentials, and what investigation do you want to do next?
Well, I mean, at least in the first instance, this woman has an abnormality, a long-standing abnormality of intraatrial septal flow. If she's in her 50s, this is not unreasonable time for patients to present with, features of right ventricular failure due to a lifelong shunt. The greatest concern would be whether or not this woman has Eisenmengers, but any of the kind of usual investigations to examine her right ventricular pressures, be it by CT with contrast, right heart catheterization, and something to get an idea of the QP-QS ratio across this lesion.
Very, very nice. Can you just quickly rapid fire tell me what are the types of ASD from most common to least common?
So most common ASD, so it's secundum, primum, venosus, coronary sinus.
Very nice, very nice. And what is the most common abnormality associated with a secundum ASD?
I would say it's probably some kind of, well, secundum might be AV valvular dysfunction, or abnormalities of pulmonary venous flow.
Nice. I think the most common in like the textbooks for the MCQ type of answers is mitral valve prolapse, but you're absolutely right about the others as well. And can I ask, so with an ASD, would you expect to see right heart dilatation or left heart dilatation, and why?
It depends somewhat on the chronicity of the situation as well.
Mm-hmm.
but primarily it's going to be a left to right shunt. So you're going to end up having a right-sided overload.
Very nice. And would you expect to see pulmonary hypertension in ASDs classically?
Well, I don't know classically, but the ones who come to theatre who present not dissimilar to this, which is reasonably asymptomatic until dyspnea or other findings in their 40s or 50s, do have a degree of pulmonary hypertension.
Yeah, absolutely. And those are the ones that I've seen as well. But I guess, you know, classically it's does your VSD, does that cause right heart or left heart dilatation, and why?
Well, again, is the pressure differential across the chambers, so it's going to be the VSDs are again going to be left to right.
Yeah. So would that give you the patient right heart dilatation or left heart dilatation? And why?
Well, I mean, it's going to be a volume overload of the right ventricle.
Yeah, so it's interesting. So with VSDs, you get left heart dilatation, and ASDs you get right heart dilatation, and that's because of the timing for when the blood is shunting through and what's happening to the AV valves at that time. So that's why with an ASD you're getting flow. You get mainly a right-sided overload because your AV valves are open, and so you're getting a complete volume load to that side. Whereas with VSD, your AV valves are closed, you're essentially getting a closed loop straight through, high pressure in systole, straight through to that pulmonary circulation and straight back as a single loop back through to your left heart. So VSDs give you left heart dilatation and classically obviously more pulmonary hypertension earlier because you're getting a complete pressure loading to the pulmonary circulation and that's coming straight back to the left side. So VSDs and PDAs give you left heart dilatation, whereas ASDs give you right heart dilatation, and it's all about the timing of the flow and what's happening to the AV valves. That's a question that they love to ask in the American exam. If you're, I don't know whether you have sat it or you're sitting it.
I sat the ASC, yes.
Yes, and the other thing to mention there is yeah, so that's the different, that's why you get left heart dilatation with VSDs. But this lady has, obviously she's got a big right heart with significant pulmonary hypertension and what looks to be maybe a bidirectional shunt. And because secundum ASDs are the most common, we think this could be, you know, common things being common, I guess, you know, the concern now is this a secundum ASD that's been undiagnosed, leading to chronic RV volume overload, which over time has led to pulmonary vascular remodeling and hence pulmonary hypertension, raised PVR, and maybe an Eisenmenger physiology, as you said, especially with the fact that she's cyanosed and has clubbing. So those were the thoughts. Do you know why I'm showing you this sign? Essentially, I'm showing you that the right atrium is bigger than the left atrium in terms of their area. And I don't know whether you've heard of this relative atrial index. There's this lovely paper, and essentially if you've got a right atrium that's bigger than your left atrium in a ratio of more than 0.9, it's pretty highly sensitive and specific for a significant ASD. So after looking after this lady in this case, whenever I see that now, I always go hunting a little bit harder for the presence of an ASD, particularly if I can't explain why the patient has significant right heart dilatation. And we had a case like this again a couple of days ago. So what might we wanted, so the thing that we did next was a toe study actually, and we looked to see if we could confirm the sort of diagnosis of secundum ASD. And Jamal, you probably have more experience in assessing the ASDs than I do, being a cardiac anaesthetist, but are you able to just talk through the RIMS that you would look at in terms of, because we know that secundum ASDs are the ones that are amenable, can be amenable to percutaneous closure, whereas the other ones, it's highly unlikely that you're going to be able to close them percutaneously. So what kind of things do you look at in terms of the RIM assessment?
Well, I mean, I think they usually have their own specialized guys to do this, and it is going more towards kind of other forms of imaging such as MRIs and things like that. But the pure things are how big the lesion is, because there are lesions that are too big for any of the percutaneous closure devices and need to come to theatre. There's also how big the rims are and how close they are to other structures. And so in this image, the rim which is closest to the aortic valve is actually quite deficient. So I would be even, I mean, it's a large lesion. There's plenty of options to size it, but the rim or lack of rim close to the aortic valve is quite deficient. And again, I don't size them for percutaneous. They're always sized before they come to me, and there are criteria, but I would be surprised if this is deemed appropriate to be closed by percutaneous closure.
Well, it's interesting as well. So this lady ended up having an MRI, cardiac MRI, and also right heart cath, and was obviously referred to a specialist, congenital and pulmonary hypertension center. And she hasn't been closed. And, they talk about the PVR, if it's more than 3, maybe that's not amenable to closure. And certainly if it's above 5, it definitely wouldn't be closed, because you'd probably, they'll probably die from that. So she's currently being managed with, pulmonary vasodilator therapy, and is relatively stable, but she's still being seen in that clinic and still having workup for that. And this is just showing obviously that huge bidirectional shunt across this massive secundum ASD. That's showing the bidirectional flow that Jamal mentioned earlier, so to and away from the probe, left to right. And this is again just trying to get a feel for the rims and trying to sort of get an assessment of the different the aortic rim deficiency, as was said there, as opposed to sort of the SVC rim and things like that, and just trying to get a feel for how big this was. Anyone has the guess as to what this structure could be? I know it's a bit. So this is the tricuspid valve. I might just point that out here. SVCs coming in here.
I mean, it is some kind of catheter or wire.
Nice. You can see it there as well, hey, in the right atrium. I don't know if you can see it better on another one. You can see it just bouncing in and out here. So it was actually a PICC line that was in this lady. But this is, I guess, sort of a kind of a non-fast view, but not really. Showing, so we're looking at the secundum ASD through from the right atrium, and we can see right through into the left atrium there. We probably see a little bit of the mitral valve apparatus, and I think it ended up being about 1.5 by 2 centimeters big. So the way that we managed her in the sort of acute setting is we obviously tried our very best not to intubate this lady, and we didn't need to in the end. We treated her for pneumonia, and I think that's probably what set off her decompensation, was the fact she developed a pneumonia and some atelectasis. So she was treated with high flow and lots and lots of diuresis. We ended up making her about 12 liters negative or something, lots of fluid off. And we started some inhaled prostacyclins as well, which she seemed to tolerate. And then she was referred to a congenital center about a week later. But we did the cardiac MRI here at Nepean, and she had her initial right heart cath done here. And it was really quite interesting, the disparity between the findings, especially for cardiac output, the shunt fraction in particular, and the SVR to PVR ratios and things like that on cath versus MRI. They were very different to each other. And it just shows you that importance of, getting these, having multimodal assessment, but also having these patients assessed at high volume centers where they're really skilled and experienced in congenital heart disease. So yeah, this was a pretty cool case for us, and we were just sort of through.
The congenital guys sometimes talk about this, and you have to be careful about the disparity, because partly sometimes what happens when they take them to cath still is that they receive some sedation and they receive some supplemental oxygen. So I've spoken to some of the congenital guys in the past who are concerned by that, because the supplemental oxygen and the small amount of sedation can alter, as you say, they can alter the findings significantly of the shunt fractions, as opposed to patients who are just kind of sat inside the magnet without any supplemental oxygen and just left to have their scan. So they do talk about that as being a cause for discrepancies between the findings of MRI and cath.
Yeah, absolutely. And I guess also the technique that's used in the right heart cath, you know, whether we're using the direct or the indirect Fick principle and things like that, like for what we're measuring, and how, you know, where in the cycle, if they've got, I don't know, if they've got concomitant MR, like where they're actually measuring the occlusion pressure and things, you know, for the calculation of PVR. There's so many things to consider, hey, with all of that. Then maybe we've got 5 minutes just to blast through this one. It's kind of a bit of a spot diagnosis one, but I think it's nice to always recap the basics. Chuan, do you want to maybe describe what we see here? This is a lady she's actually presented relatively stable, but has come in for a valve procedure.
Yeah, that's good to hear. Yeah, so we're on the left, there's a parasternal long axis image, and on the right, there's a apical four-chamber, and the major abnormality appears to relate to the mitral valve. Hyperechoic material in both leaflets appears to move in time with the leaflets, I guess.
Yeah.
Doesn't look independently mobile to me.
Yeah. So not independently mobile, kind of fixed at the leaflet tips. Is there anything else about how, so what are the main types of mitral valve, you know, sort of pathology, like in terms of, are we, you know, the two sort of, I guess there's lots of different types, but in terms of acquired problems with the mitral valve, they can be largely divided into degenerative and rheumatic. And what would be the features of the features of a rheumatic valve, like where you would expect are there any sort of pathognomonic features that you've heard about with rheumatic valve?
Yeah, hockey shaped leaflets.
Nice. Yeah. So what do you think? Yeah, sorry, John.
And the dilated left atrium as well.
Very nice.
Mega LA, giant LA.
Yeah, absolutely, because of the remodeling from the mitral stenosis. But I'll just point out a few things. So do you see that this, I guess it's either called diastolic doming or a hockey stick appearance. Sometimes when you've got this big thickening at the tips, it can sometimes mask that sort of movement. But can you see how you have that sort of doming hockey stick appearance? I don't know, I guess hockey sticks, you know, but can you appreciate that of the anterior mitral leaflet?
Yeah.
That diastolic doming, which you can see just there where my pointer is, how it sort of domes upwards. So that's the hockey stick. The other, I guess the key features are that nothing's ever completely diagnostic, but I guess a history of rheumatic fever. And then classically the leaflets tend to be thickened at the tips, as opposed to in degenerative mitral stenosis, where you get lots of, you know, mitral or basal thickening and calcification, or mitral annular calcification. And generally the tips tend to be more preserved in degenerative mitral stenosis. It tends to be more calcific. So I guess those are the two main features. And the other features with rheumatic valves is that you get the leaflet thickening, you get the hockey stick or dome diastolic doming. You also get later in disease, you get restriction of the posterior leaflet. Can you see how this posterior leaflet's not moving at all? And that's pretty classic for rheumatic mitral stenosis. And then the other things you might see is, I guess the hallmark is the commissural fusion. And that's what differentiates it from more degenerative disease. But you can appreciate that more in the short axis view. And then other things that you might get is subvalvular thickening and sort of thickening of the cords as well. And that's, you use that, you know, when they're working out whether to do things like balloon valvuloplasty and stuff like that, they use the Wilkins score to decide on that, and that includes analysis of the actual leaflets as well as the subvalvular apparatus as well. Spot diagnosis here with this one, you know, they might show you like a loop like this in the exam and say, like, what could this be? And do you know what I'm sort of trying to demonstrate here? It's the patient from this loop. It's the same patient. It's just, well, you could tell me what it is, John. What do you think it is?
I mean, it's an M mode trace through the mitral valve, and
Very nice. Yeah.
there's I think I might have to get Jamal to help me out with this.
Yeah, Jamal, I think Jamal knows this one. I might have heard you talk about it before.
I don't use a whole lot of M mode, I have to say. Not for this either. That's what 3D's for.
No. Oh yes, I like 3D too, but I also like I love M mode, especially when it's just classic like this. So it's always nice to have in, and you know, it's not going to help you change management or anything, I don't think, but it still makes pretty pictures. So it's this classic reduced EF slope. So this is not your E, that's your A, and you have this F slope in between. And normally this will sort of come down and you'll get that move, you know, and then it'll go to the A wave, but you get this reduced slope of this F here. So it's called a reduced EF slope. And other things you can pick up is that the patient is probably still in sinus rhythm, sinus bradycardia, but often in mitral stenosis, you'll see just a straight flat line, so you won't see that A wave there. And you can see that the posterior leaflet's not moving very much. This is a classic M mode picture of rheumatic mitral stenosis. So I like to include that kind of thing in the quiz. Do you want to maybe comment on this, Joanne, like what we can see with colour?
Potentially there's mixed valvular disease. There's definite, at least moderate, not severe mitral regurgitation. It's an eccentric jet that's wall hanging, and extends right to the posterior LA. Very
nice, lovely. And what's the physical principle that leads to this wall hugging?
The Coanda effect.
Very nice, very nice. Now, would you? Yeah, very nice. How about?
There's during diastole. There's also alleviating of the color flow Doppler, which makes me suspect that there might be stenosis as well.
Lovely.
So to interrogate with a continuous wave Doppler.
Yeah, really nice. So this sort of candlelight flame, you know, the candle flame classic, and you're absolutely right, this alias thing and this Pisa dome that's forming there, suggesting that there's, and obviously the 2D appearance, you're suspecting stenosis, but there's also probably, you know, moderate to severe regurg as well, which we'll not spend a lot of time on how we categorize all of that on today's session. But this is what you get. So you get we put continuous wave through and we get a mean gradient of 7 and a pressure half time of 160. What does the mean gradient sort of tell you in this context?
There's mild stenosis. I think the cutoff's 5. Yeah,
so it changed actually, and I might just go to this slide. So I guess we all kind of still stick to this from 2009. That was in Jason. It's probably reasonable still to do that. At least we're going to figure it out. But yeah, you're absolutely right. The mean gradient less than 5 mile, 5 to 10 moderate, and more than 10 severe. But now it's moved to, you know, really de-emphasizing the gradient, because the gradient is, and these are the newest guidelines by Otto in 2020, you can see there's nothing about gradient on there. In fact, there's a little comment at the bottom that says mitral gradient no longer included, but 5 to 10 is consistent with severe. Right, and they talk about the diastolic pressure half time and the mitral valve area, you know, planimetered, 3D planimetry is probably best, looking at the pressure half time, which again has things that affect it, which we'll go over another time, and also the pulmonary artery systolic pressure and signs of remodeling of the LA, and symptoms have got to match. You know, if you've got discordant findings with symptoms, for example, if you've got findings like that but the patient's asymptomatic, you need to exercise that patient, and no doubt they will absolutely get symptoms. So that if you've got discordant grading, then you need to investigate that more, maybe with exercise testing. But I just want to say what things so we've got a gradient here of mean gradient of 7. What things about this patient, if we look at this, might elevate that gradient, that might give you a falsely high gradient, making you think that there's, you know, more stenosis than possibly there is.
On the loading status of the patient.
Very nice. Yeah.
So they've got dilated left atrium, and so you would suspect they've got chronically dilated left atrial pressures, but can't remember what else would affect.
Yeah. So what's this? All of this.
Oh, then the regurgitation.
Absolutely right. So it's the flow, like I guess the flow conditions as well. So if you've got this big regurgitant jet coming all the way back and going through, that's going to elevate your gradient as well. So you know, mitral regurg. And then there's another big thing that we need to be really mindful of when we're interpreting the gradient in mitral stenosis. I might just point to it down here.
Heart rate.
Yeah.
They're very nice. So if I increase this patient's heart rate, what will happen to the gradient, Juan?
It will decrease, increase.
Yeah, increase. Yeah, nice. No, yes, it will increase because you've got less diastolic filling time, and you know, it squeezes through, and it's at a higher gradient. So with tachycardia, you increase your gradient. Very nice. That was just a little whistle stop of that. And I was going to ask a little bit about all of that, but I need to go and do another transesophageal echo. Actually, I'm running a little bit late for that, so I might leave this one till next time, which is a pretty cool one. But Annie, thanks for joining, and it's really good to just, you know, talk through these cases. We are going to have a more formalized education program coming in the next few weeks, hopefully. We're just putting the program together, but in the meantime we thought it would be fun just to have some echo geeky chat about some cases while we you know, develop our program and put that out there. So thanks for joining, and hopefully we'll continue to see you and just keep having some fun with critical care echo stuff.
Thank you very much, Emma.
Okay,
that was great. Thank you.
See you.
Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.